Hello, my name is Kenneth Sack, and I'm going to walk you through our chapter on the assessment and treatment of ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis. Both ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis are ankylosing conditions of the spine. Ankylosing spondylitis is an inflammatory condition primarily affecting the axial skeleton, and is the major subtype of the seronegative spondyloarthritis. DISH, on the other hand, is a non-inflammatory disease primarily consisting of ligamentous ossification of the anterolateral spine in the setting of other metabolic derangements. Both clinical entities, while distinct, can be causes of back pain as well as stiffness, reduced range of motion, and ultimately spinal deformity. Both conditions have extraskeletal manifestations that may need to be considered in the process of diagnosis and treatment. Ankylosing spondylitis comes from the Greek words spondilo, referring to the spine, and ankylo, which refers to the structural deformities or angulations that occur as a result of such disease. Sometimes referred to as Marie-Strumpel disease, it is a multi-system inflammatory disease which affects primarily the axial skeleton and sacroiliac joints, and which can be associated with other autoinflammatory conditions. The overall prevalence of ankylosing spondylitis can be hard to predict and varies depending on geographic location, but has been estimated to be between 9 and 30 per 100,000 people. The prevalence of the disease closely mirrors the prevalence of the HLA-B27 gene in the general population, which leads to a higher proportion of people carrying the disease in the European populations. There is a male predominance that varies between different studies, but is somewhere between 2 to 3 to 1. Population as well as twin genomic studies estimate the determination of ankylosing spondylitis to be between 80 and 90% genetic, and the genetic correlation between HLA-B27 gene and the development of ankylosing spondylitis is one of the strongest disease associations in any inflammatory human disease. In addition to quality of life considerations for patients with ankylosing spondylitis, the disease carries a heavy socioeconomic burden as well. One study estimated the 5-year cumulative cost for ankylosing spondylitis at nearly $34,000. This being both direct and indirect costs, largely driven by functional disability. Clinical features of ankylosing spondylitis are typically insidious in their onset, which can ultimately lead to a 7 to 9 year delay in diagnosis. Patients may begin to develop symptoms at a young age, sometimes before the age of 16. The majority of patients will begin to experience some symptoms before the age of 30. This in part is due to the nonspecific nature of symptoms, as well as the lack of any specific laboratory testing available for the condition. Radiographic progression is slow, and patients typically complain of back pain, particularly with stiffness worse in the morning that improves throughout the day with activity. This gradually becomes worse over time while radiographic progression mounts. Perhaps one of the most well-known features of ankylosing spondylitis is its association with other seronegative spondyloarthritis, such as inflammatory bowel disease, psoriasis, or reactive arthritis. These associations can be seen in up to 15 to 20% of patients with ankylosing spondylitis. Patients may also exhibit some of the hallmark findings of these spondyloarthritis, such as peripheral arthritis, enthesitis, or anterior uveitis. As disease progresses to late-stage ankylosis, fixed kyphotic deformities may develop, which places patients at increased risk for fractures, even from minimal traumas. When evaluating patients for ankylosing spondylitis, typically those who present for evaluation will complain of long-standing back pain, which has failed multiple non-surgical treatment options. As stated earlier, symptoms on history may be vague and nonspecific, as well as physical exam findings. Often the diagnosis can be missed if not kept in mind by the examiner. The most specific symptoms include back pain, which occurs during the second half of the night, early morning joint stiffness lasting 30 minutes or longer and improving with activity, or alternating buttock pain referred from the sacroiliac joints. Several points specifically should be noted and evaluated in patients with suspected ankylosing spondylitis, particularly thoracolumbar spinal excursion, as well as the notation of any chest excursion. Thoracolumbar excursion can be evaluated with the Schober test, performed by marking a 15 cm length of skin which extends from 10 cm above the lumbosacral junction to 5 cm below. With flexion, the length of these marks should increase by more than 5 cm. Less than 5 cm extension may be indicative of joint stiffness or ankylosis. There is only a limited role for evaluation of laboratory markers. It is possible to test for the HLA-B27 allele, but subtyping of this plays little value in disease diagnosis or prognosis. C-reactive protein may be elevated, but is nonspecific. It may be used in patients with known ankylosing spondylitis to follow degree of active inflammation. However, only half of ankylosing spondylitis patients will have an elevated CRP. Other laboratory markers are being investigated currently, but have no active clinical role in the diagnosis. Over the years, two sets of diagnostic criteria have been developed based on both clinical and radiographic criteria for diagnosis of ankylosing spondylitis. The New York criteria, which predate the Assessment of Spondyloarthritis International Society criteria, are based primarily upon the presence of high-grade sacroiliitis in combination with clinical symptoms of axial spine inflammation or ankylosis. The more recent ASAS criteria hinges on the diagnosis based on either MRI, which has a slightly higher sensitivity for active inflammation, or the presence of the HLA-B27 gene. These in combination with clinical features of either spondyloarthritis or sacroiliitis. The approximate sensitivity of the ASIS criteria is between 68 to 87%, with a stated specificity of 62 to 95%. Radiographic evidence of ankylosing spondylitis remains an important feature necessary for diagnosis, regardless of the criteria used. In either case, sacroiliitis is the hallmark of radiographic diagnosis of AS, as it tends to occur first and has high prevalence among ankylosing spondylitis patients. The New York criteria specifically grades the degree of sacroiliitis on a scale from 0 to 4, with 0 indicating no changes and grade 4 representing complete and total ankylosis. Other radiographic features associated with ankylosing spondylitis include Romanes lesions, which are inflammatory areas along the edges of vertebral bodies with reduced T1 signal intensity and increased stir signal intensity on MRI, indicative of bone marrow edema. Syndesmophytes are bony outgrowths present along the edges of vertebral bodies, which are a precursor to ankylosing autofusion and can be seen on both conventional X-ray as well as MRI. Spondylodiscitis, also known as Anderson's lesion, is an inflammatory lesion of the intervertebral disc characterized by hyperintense stir signal and hypointense T1 signal. Enthesitis, which is an inflammation of the entheses, or sites of tendon or ligament insertion, occur most prominently in the interspinal and supraspinal ligaments, as well as the ligamentum flavum, and may be noted by increased signal intensity on stir imaging. Perhaps the most well-known imaging finding associated with ankylosing spondylitis is the bamboo spine, which can be seen on conventional X-ray of advanced disease in which multiple vertebral segments have become ankylosed, likening them to a reed of bamboo. The figure to the right from Ostergaard et al. Identifies several conventional X-ray features of ankylosing spondylitis. At the top left, one can see sacroiliitis of the bilateral sacroiliac joints with bilateral erosions. Top right features multi-level bridging syndesmophytes, which have resulted in cervical ankylosis. The bottom two images are the same conventional X-ray of the lumbar spine in a patient with advanced disease and multi-segment ankylosis of the lumbar spine, as well as grade 4 sacroiliitis and complete fusion of the joints. Though many findings in moderate to advanced ankylosing spondylitis are clearly evident on conventional X-ray, MRI has become an important imaging modality for both quantification of inflammatory changes as well as monitoring progression in these patients. MRI has the advantage of being able to detect active inflammation as opposed to simply the sequela of such inflammation visible on X-rays. There is little role for CT scan, owing to the inferior sensitivity for inflammation and comparatively large radiation dose. One tool used for chronicling the progression of radiographic features of ankylosing spondylitis is the modified Stoke Ankylosing Spondylitis Spinal Score. This scale assesses the axial spine and sacroiliac joints along 24 separate locations, each being graded with a rating of 0 to 3 based on the presence of sclerosis, vertebral body squaring, or syndesmophytes. It has superseded the older Bath Ankylosing Spondylitis Radiology Index. The pathophysiology of ankylosing spondylitis is based on chronic inflammation of the entheses, which causes osteoproliferation and ultimately ankylosis. Inflammation in ankylosing spondylitis can occur throughout the skeleton, but most commonly occurs in the weight-bearing parts of the skeleton. For example, the sacroiliac joints, vertebral bodies, entheses, which supports the notion that mechanical stress may play an important role in disease initiation. Although the clinical association between HLA-B27 gene and the disease incidence is well described, the pathophysiologic mechanism has not been well elucidated. Recently, 2 additional genes have been implicated pathophysiologically in HLA-B27 positive AS patients. The IL-17 and IL-23 axis, which mediates joint inflammation as well as bone remodeling, has also been implicated based on the therapeutic success of the biologic anti-IL-17 agent secukinumab. We can now turn our attention to the second ankylosing condition described in this chapter, diffuse idiopathic skeletal hyperostosis, commonly referred to as DISH. DISH is a systemic condition characterized by progressive calcification and ossification of spinal ligaments as well as entheses. It was first described in 1950, and historically little clinical significance has been attributed to it, as the disease is primarily a radiologic diagnosis and can often be asymptomatic. However, DISH can be associated with a number of metabolic derangements, including cardiovascular disease, obesity, diabetes, hypertension, hyperuricemia, as well as biomechanical changes of the musculoskeletal system. As the disease is largely asymptomatic, it is difficult to accurately report or estimate prevalence, though it is suspected to be much more common than initially thought, with some estimates reaching as high as 25% for men over 50 and 15% for women of the same age. As patients with DISH are often asymptomatic and clinical findings can overlap with many other conditions, DISH may often go unrecognized. The hallmark findings of DISH are radiographic in nature and consist of calcification and ossification of spinal ligaments and entheses, with a predilection for the anterior longitudinal ligament. DISH may affect the entire spine, but most frequently affects the thoracic spine. One important feature to note radiographically, which helps define the disease, is the preservation of the intervertebral disc space without evidence of spondylodiscitis. Enthesophytes may be coarse, large, and span multiple vertebrae, which can lead to problems with dysphagia or esophageal dysfunction when located in the cervical spine. Some extraspinal manifestations include peripheral joint arthritis or heterotopic ossifications in the soft tissues. DISH is associated with a number of metabolic derangements, including obesity, hypertension, diabetes, dyslipidemia, or hyperuricemia. The diagnosis of DISH is based solely on radiographic criteria, first established by Resnick and Naoyama in 1976. Criteria are based on the number and contiguous nature of flowing osteophytes, concomitant with preserved intervertebral disc height, as well as the absence of sacroiliac joint involvement. Utzinger proposed an alternative set of criteria, as well as different degrees of certainty of the diagnosis. As one can see from evaluating the table, the primary debate lies in defining how many consecutive vertebral bodies with hyperostosis constitute the disease. Radiographic features of DISH include irregular bridging ossification of the annulus, as well as the anterior longitudinal ligament or paraspinal connective tissues. Typically, these have an anterior distribution, and in places where the aorta is also present, have a predilection for the right side. As stated before, the thoracic spine is most commonly involved, and by definition, the disc spaces are preserved. There may also be ossification of the posterior longitudinal ligament or the ligamentum flavum in up to half of all cases. The figure at right shows the bridging osteophytes across multiple segments, as well as mostly normal intervertebral discs with preserved height. The triangular ossicle, denoted by the arrows, can help differentiate from osteophytes seen in more common spondylosis. As noted earlier, DISH does not feature sacroiliitis. Though multiple contributors have been identified, such as genetic, metabolic, and vascular factors, the exact pathophysiology of disc remains unclear. A single gene, COL6A1, has been identified as contributory in ossification of the posterior longitudinal ligament, or OPLL, which encodes type 6 alpha chain collagen molecules. It was shown in a small study to be associated more strongly in DISH patients without OPLL than in those with. The metabolic derangements so often concomitant with DISH, particularly the role of insulin or growth hormone, have been postulated to be involved in pathogenesis, but this has not yet been elucidated scientifically. With the exception of patients who have ankylosing spondylitis with advanced disease and kyphotic deformities, management of ankylosing spondylitis is primarily conservative. The 2016 European League Against Rheumatism set out overall therapeutic goals as well as means by which to achieve those in their recommendation. They defined the overall therapeutic goal as maximization of long-term quality of life, and to accomplish this through control of symptoms and inflammation, as well as prevention of progressive structural damage and preservation of function. They noted that optimal treatment is both pharmacologic and non-pharmacologic, and focused on lifestyle modifications such as exercise or physiotherapy. The first-line therapy for management of ankylosing spondylitis for patients with mainly axial back pain or functional mobility limitation is nonsteroidal anti-inflammatory medications. While intra-articular corticosteroid injections can help with specific joint pain, they are not routinely recommended for patients without a specific indication. Additionally, systemic corticosteroids are not recommended in the management of ankylosing spondylitis. Though disease-modifying anti-rheumatic drugs can help minimize disease, they are not recommended for patients who have axial disease alone. Patients who do fail conservative measures may be considered for biologic DMARDs, such as TNF or interleukin-17 inhibitors. Similarly, treatment for DISH is also directed primarily at symptom management and minimization of systemic comorbidities. As with ankylosing spondylitis, NSAIDs are the first line of treatment and can provide good benefit for those patients who are experiencing symptoms. A healthy exercise regimen is also recommended to improve and maintain mobility, and to prevent functional limitations as patients age. Additionally, it may help with peripheral joint pain that some patients experience. The European League also recommends trials of alternative therapies, such as glucosamine chondroitin, topical capsaicin, or intra-articular steroids, though they have not been strongly supported by the literature. One of the more important facets of management of DISH is the minimization of comorbidities, particularly cardiovascular and metabolic risk factors, which increase the overall risk of a number of other conditions. In both of these conditions, the ankylosing disorders can cause pathologic bridging of continuous vertebral bodies, which increases the lever arm of forces throughout the axial spine and places patients at a higher risk for fracture. This risk is worsened in the setting of kyphotic deformity. One study showed that the hazard ratio for spinal fracture in ankylosing spondylitis patients is up to 7.7. Additionally, the risk of neurologic deficit in these patients after fracture is higher than in the general population. Patients with AS who do experience fracture typically do so as a result of hyperextension, most commonly occurring between the C5 to C7 levels. Other risk factors for fracture include low bone mineral density, male gender, long disease duration, higher radiologic ankylosing spondylitis grading scores. In these patients with known ankylosing disorders and a history of even minor trauma, thought should be given to their increased risk, potentially necessitating CT, to rule out even minimal fractures that may be missed on plain radiography. Surgical management of these diseases is largely discussed in deformity correction chapters of this text, and is not discussed further here. Surgical intervention should attempt to address instability as well as restore balance of the sagittal and coronal planes. The final slide of this presentation reiterates key concepts from the chapter and are presented here for your convenience.